now very old, so accumulate for a long time. This morning I want to just say one word. Bicêtre is just coming the route from Westminster, because we have a common king between France and England, so it's 20 centuries of war. And my hospital was just in the south of Paris and was owning from the Duke of Westminster. But French are unable to pronounce Westminster, so it's Westminster, Bismarck, Bicêtre, Bicêtre. We have the book with all the time since my hospital is open for the public since 1229, so it's the oldest hospital in Europe. It was also a prison too, because at the time in France, most of the hospitals were also prison. Just starting, because I must say that I'm still speaking this morning about recombinant proteins, and see if I have some time is speaking about belatacept and also alafacept. I must say that I'm not a BMS employee. I work in fact in belatacept and alafacept. This is from BMS and this is from Astellas. And the reason why, because I was the coordinator, the tricontinental coordinator for belatacept and alafacept. Just a small story. I met Chris Larsen and Alan Kirk, I mean, a long time ago when I was postdoc in Ron Guzman's lab in McGill University. And they are two surgeons, but they are very smart. And in fact, they published the first paper in Science in 2001. And 11 years after, the concept of blocking the second signal now came true, and you have the product close to the market, as you may know, for belatacept. It's now marketing in US, and unfortunately enough, the second one, alafacept, will be stopped, because even after the phase 2 and the phase 3, Astellas has stopped the production from alafacept. So it's a typical example of clinical investigation, phase 2 and phase 3, when you have a success and an unsuccess. For some reason, I have maybe some time to discuss with you. Just to say, as a nephrologist, I'm a problem by prescribing since 1981 cyclosporine A, because I'm prescribing a nephrotoxic drug. So as a nephrologist, it's not very clear to give a nephrotoxic drug. So as you can see, I'm doing a lot of transplants since the early 70s. I have 3,000 patients on my waiting on my file and outpatient clinics, and I have 1,000 patients waiting on my waiting list. So this is the problem that we are facing in many countries. This is the long-term patient graft survival and has not improved over the last decade despite decreased acute rejection rates. This is true under calcineurin and anti-mTOR drugs. Renal function remains the important determinant of long-term outcomes, and as you may know, a lot of patients disclose evidence of chronic allograft nephropathy, now called interstitial fibrosis, and tubular atrophy remain the leading cause of the late graft loss. And 70% at 5 years, when you're doing a regular biopsy, Necker is doing that every year, you have evidence of CAN on your transplant. So it's meaning that all the transplants are not really assessed as perfectly tolerated, but have some evidence of, in fact, CAN. And the second one is now, I started the transplantation with a lot of patients who are dying of pneumonias and so on. And now, most of those patients in post-transplant period are dying of cardiovascular disease. This is the most common cause of mortality with functional grafts. This is normal because you are accumulating the risk during dialysis, pre-dialysis, and then afterwards. The lipids problem, the blood pressure problem post-transplant, and then most of the patients are dying with cardiovascular disease. And lastly, CNIs, tacrolimus and cyclosporine as associated with nephrotoxicity and cardiovascular and metabolic side effects. So just recalling, I am immunologist basically too. It's very difficult and complicated, but as you may know, T cells are needing 3 signals to be activated. The TCR, which is the signal 1, and a lot from the signal 2. And the signal 2 is here. You have a lot of molecules that can do block. The one I want just to speak about is CD28 and B71 and B72 as a co-leader on the antigen-presenting cells. And this is another one, for example, alafacept are blocking CD2 and LFA3. So this is really the synapse between the antigen-presenting cells and the T cells. So belatacept was in fact invented before that BMS bought the license in the Emory University in Atlanta by Chris Larsen and Alan Kirk. And this is in fact the exterior domain from CTLA4. But the problem with CTLA4 that you can call as Orencia, you are using it in pediatric rheumatoids. has a very short life and a few bindings to the ligands. So they have to be modified by 2-point mutation inside the modified CTLA4. And then the recombinant protein is associating a modified CH3 molecule from the modified IgG and giving you the first-in-class co-stimulation blockers, and it selectively inhibits the T-cell activation by blocking the effect between CD28 and BCL1 and BCL2. This is the first biologic maintenance immunosuppression therapy, and it's only administered TIV. It could be a problem for many centers, and I was thinking that was the case in my opinion. So this is just a cartoon showing you the APC, the T cells. This is a signal 1 between MHC and the TCR, and one of the signal 2 is CD28. CD28 is normally binding to CD86 or 80, and belatacept is blocking this binding. As soon as you have one signal, but not the second signal to T cell, and not the third signal, which is IL-2 receptor, you have no cell division, no cytokine production. The T cell is becoming anergic, is immune but unable to proliferate, and is becoming apoptotic, a self-suicide inside. So it's a way to block T cell activation after the first activation. So I was the coordinator, the tricontinental coordination of the phase 2 long time ago, because now I'm starting with the first patient 8 years ago, and the phase 2 is just showing you about the consistent number of patients, more than 200, and we use less intensive regimen versus cyclosporine A, and we saw similar rates of acute rejection at 6 months, better GFR at month 12, less chronic allograft nephropathy, and better cardiovascular and metabolic profile. So this is the reason why BMS, after this phase 2, jumped in a phase 3 with a lot of advantages. This is also to show you as nephrologist during the phase 2 and long-term extension at 5 years, the main differences between the calculated GFR on belatacept and the main calculated GFR on cyclosporine A. And as usual, you see during the time a drop down, a negative slope for cyclosporine A because it's nephrotoxic and cardiac and can, and for the belatacept less intensive, a fairly slow, fairly plateau. And this is on a lot of patients, because at 5 years for the phase 2 we have already 75 patients enrolled in this stuff. So we have divided the big tricontinental study in 2 arms, which was very expensive and very difficult to set, but it's fine. Benefits, which is in fact for adult recipient of graft from living and standard criteria deceased donors. This is typically what is going on in US, and we urge to have another arm, which is called Benefit X, for adult recipient of graft from extended criteria kidney donors. This is typically what's happening in Europe and mostly in France. And just telling you that in US it's 60% of living donors, 40% deceased. In France, 8% living, 92% deceased donors. So this is the protocol we had, and it was just coming from the monkey trial we had with Chris Larson and Alan Kirk. This is more intensive. You have the belatacept at 10 milligrams per kilo during the first 160 days, with a lot of infusion there until 6 months, and even afterwards 5 milligrams every 4 weeks. So the compound is given only once a month. For less intensive, you have less injection during the first 3 months, and then 5 milligrams every 4 weeks. For cyclosporine, this is a regular step, 150 and 300, and then 250 for all the run. All the patients receive basiliximab as induction, here again because it was on the monkeys, and we have synergistic effect between belatacept and Simulect during the monkey trial. And then we use it in human, and then MMF and corticosteroid. You can ask, why cyclosporine? As you may know, in States, you have to negotiate before you launch the clinical investigation with FDA and NIH, and they need at that time to have cyclosporine A and not tacrolimus as a control group, because in US at that time, 10 years ago, a majority of patients were under cyclosporine and not on tacrolimus. And then it's an open question to have this trial with tacrolimus and not cyclosporine. But to register these molecules, they need at that time to have cyclosporine A. So this is the surviving curve with functioning graft, the same that cyclosporine 93. I guess in Israel you are working with 4 to 6% of deaths at 1 year. It was the same for cyclosporine 97 and 95 for less intensive and more intensive. So it's meaning first that belatacept is not killing patients, which is the first very important ground. The second one is composite renal impairment endpoint. This is all the patients who have GFR below 60 ml per minute or decreased GFR from month 3 to month 12 superior to 10 ml. And as you can see, cyclosporine is more nephrotoxic. You have a less and good renal function for belatacept LI and belatacept MI with clearly fairly differences. It's quite normal because we are expecting this type of curve because we are not using a nephrotoxic drug. This is now measured and calculated GFR between MDRD and yotolamate. It was mandatory to do that. And here again, you have a clear differences between cyclosporine 50 ml and 65 ml. So it's giving 15 ml of better clearance for the GFR, yotolamate, and approximately the same for the MDRD formula. So this is the MDRD over the time, and here again you have a kind of plateau for the belatacept, and this is also for cyclosporine. As you can see, the main advantages is seen very early, 1 month post-transplantation. It's sustained over time. This is another very good point. Now this is the acute rejection episode at month 12, and you can see you have more rejection in MI and less than LI and few one in cyclosporine. So it's meaning first that maybe belatacept alone is not sufficient to induce a true tolerance during the first months. And as you can see here again, some were in fact moderate acute 2A bound grade for MI and for LI and less in cyclosporine. All those acute rejections were highly reversible by increasing steroids and giving sometimes ATG. And in fact, here again, those acute rejections was not deleterious to the renal function, because I will show you the fact that afterwards, treating by this acute rejection, you will see that the clearance will be becoming normal. So this is an issue that we should discuss with you. So this is the GFR with or without acute rejection. This is with acute rejection without, a little bit 4 ml of differences, 4 ml of differences, and again 3 ml of differences. So it's better to have no rejection episode, but you have one rejection episode, you can treat it and coming back to quite normal functions. So now I want just to the new ones is the ECD kidneys, because in fact this is a normal rule in Europe, and the extended criteria donor transplant is becoming very more common to increase. And for example, in Bicêtre we have one of the main breast dense center in France, and we have a lot of harvesting of very old person and people. And this is associated with reduced survival rates because you are using a pretty bad graft. So, and also ECD transplant recipients are vulnerable to the renal and non-renal toxicities of CNI. So we use, because it was a US devices, we use the UNOS criteria. It's for us quite nothing, because donor age is superior to 60 years old, in BCAT is superior to 70 years old. Donor age between 50 and 55, and two of the following: cerebrovascular accident, hypertension, serum creatinine. This is a usual life of many patients dying of medical causes. Anticipated cold ischemia time superior to 24 hours in France is 48 hours. And donor with cardiac death, non-heart beating donors, it was very, very few 8 years ago, and now it's 20% of my transplantation in BCET are done with cardiac arrest in the emergency room. So the donor characteristic is meaning just the fact that a lot of patients were above 60 years old in both arms. Age 50 to 59 with risk factor 19, 25, and 22. Cold ischemia time superior to 24 hours, a lot, 40%, 43, and 44. And DCD, 10%, 11%, and 10%. And now for me, it's 20%. So it's a twofold more for the DCDs. Here again, the surviving functional graph, 85, 89, 86 for ECD. I must tell you that in this setting, the graph and the recipients are in worse situation than for the benefit. Now, the composite renal impairment, the same. 85% for the cyclosporine, 77 and 71 for MI. So it's clearly that we choose, in fact, afterwards, the LI to MI to propose that in a clinical practice. This is also the measured and calculated GFR by month 12. Here again, 45 ml, 50 ml, 52 ml for yotolimate, and for the MDLE formula, 43, 50, and 50. Here again, you are gaining a lot by using Bella regarding that. For the rejection episode, here again a little bit more, but very few one regarding MI, LI, and cyclosporine. 10, 17, 17 for 2B, 16, 8, and 5. Why more moderate acute 2B? Difficult to say. It's maybe because we use, in fact, basiliximab and not, for example, ATG. And I will show you some few patients in phase 2 using ATG instead of IL-2R, monoclonal antibody. Now, the CAN. CAN is very important because, as you may know, as nephrologists, this is a threat for us, and a lot of patients on CAN. So if you see the benefit, 30%, 32% have disclosed evidence of CAN, 24 for MI and 18 for 24 for LI and 18 for MI. And benefit is less well pronounced because this is all kinase, bad kinase, and worse kinase, and it's 52, 46, and 45. So when you pull the analysis, it's 41, 34, and 30. So the consequence of that is the half-life of your kidney under Bella would be better than under cyclosporine. Maybe you are gaining, I will show you a curve, gaining 2 years for the same kidney, the same recipient, 2 years by using a non-nephrotoxic drug. Another issue I want just to discuss is PTLD. PTLD was more frequently found under belatacept. The total PTLD were 8, 6, and 2, and most of these PTLD were in fact localized in the central nervous system, 6 and 3. What was the evidence after we saw the data is in fact that in US you can put your patient on a waiting list without any ED of the serological status for EBV, for CMV, and whatever you want. In France, in Europe, we have a kind of state agency, and you have to put all the algorithm on the flow sheet for the patient before to be on the waiting list. So it's mandatory to have EBV status, CMV status, and everything for HIV and so on. And most of this PTLD were seen in the EBV seronegative patient receiving an EBV seropositive patient. It's meaning that you are blocking a second signal, blocking T cell during a primary infection of EBV. So it's mandatory now to avoid any transplantation on belatacept with EBV seronegative patient. And as you may know, when you are a young man going to the movies or young female, you have the EBV by just exchanging saliva. So at 80% in France with EBV seropositive and 20% of seronegative. I guess in Israel it's a little bit more, 85 because maybe you are sexually more active than us. And in fact, the big problem is because most of this PTLD happened not in Europe, but in States. And because it was, all the patients were not typed for EBV. So it's mandatory. And I guess in Israel, you need to have the CMV, EBV, and so on status before to put them on a waiting list. So the main advice, please never transplant those patients under Bella with negativity for the serology. So this is now the projected mean graph life. And this is compacting benefit and benefit X. And you can see 50% of the patient. And this is the less intensive regimen. This is cyclosporine. Same kidney, same recipient, and so on. And this is a it's projective mean graph of life. And you see that under cyclosporine, this is 4,000 days. And with belatacept, it's 4,700 days. So it's meaning that you are gaining close to 700 days for the same kidney, the same recipient, and so on. So you are gaining 2 years. And for us in France, 1 year dialysis is 45,000 euros. So when you are doing that, 2 years in 90,000 euros. So the conclusion versus cyclosporine 3 years is comparable percentage of patients surviving. 20 ml of better renal function. As you may know, we are losing 1 ml of clearance every year after 40 years old. New acute rejection episode with Bella after 1 year, lower overall frequency of DSA and de novo DSA, And principal safety concern is to the PTLD, especially CNS PTLD, and 2-year benefits of graft life. So I want just now to come back to the safety profile, because safety profile is very important for us as nephrologists, because we are following the patient for years and years and years after transplantation. So I want just to come back to not the success of Bella, which is now well demonstrated, and we have published in New England Journal of Medicine for AGT and so on. And for me, the only reward I have from BMS is because I published, because all my fees were given to hospitals who have nothing to, have no share from BMS. Maybe it's wrong, but it's like that. And I want just to see the death, infection, and malignancy. This is, in fact, the problem that we have to analyze these things over the time. So the combined exposure, it's a lot of patients over 12 months, over 12 months, and 3 years. As you can see, you have more than 250 patients on every arm in this study. So it's very costly, but it's very informative, and we have a lot of bunch of data regarding that. So adverse events, like in every clinical trial, you have to check everything. A lot of adverse events, 99% for all 3 arms. The serious events, the same ratio for all the 3 arms. And the discontinuation is surprisingly pretty low, 12%, 13%, 19% for cyclosporine. So this is the deaths, 14 deaths, 9 deaths, MI, LI, and 15 cyclosporine. Deaths to 2 years, 20, 19, 25, and deaths to 3 years, 31, 25, and 32, which is quite comparable in every arm. So this is the time to death at 3 years, and I can see that the less intensive regimen is better regarding the probability of death. And here again, this is a reason why we choose to propose the less intensive regimen compared to the major intensive regimen, which is relatively close to the curve of cyclosporine A. Second, this is a selected infection through 3 years. As you can see, 13% of CMV disease, 13% for CMV there, and 14% the same. So CMV is not taken aback by Bella compared to cyclosporine A. Herpes, the herpes is always the same, 7 for 7. The fungal infection, 24, 17, 22. And I'm sorry for tuberculosis, it is my own center, because we have an outbreak of very severe tuberculosis coming from Black Africa. And those patients contaminated other patients, and he also contaminated 3 nurses and 1 doctor. So it's a very strong outbreak of very resistant mycobacteria. This is, I want just show it. So this is now the time to serious infection through the year 3, and here again you can see that it's better for less intensive regimen compared to more intensive and cyclosporine, with a pretty large number of patients at 3 years, more than 180. So now the malignant neoplasm, here again as nephrologists, as you can see, we are facing this problem of cancerogenesis post-transplant, all malignant neoplasm, 34, 25, and 31, the same. Non-melanoma skin cancer, which is a threat in some countries, and as you may know in Australia, this is a very good, strong threat, and maybe in Israel because you have a lot of sun too. It's 18, 6, and 15, and PTLD are already spoken about, 5, and 1. So this is the lymphoproliferative disorder, I tell you, so it was disseminated in 3 cases for cyclosporine A. PTLD on belatacept is, for surprisingly enough, 6 on CNS, 3 on LI, and fatal in 3 cases and 3 cases there. So the number total of PTLD, fatal PTLD cases was 4, and 3. This is the demonstration that I told you about PTLD and EBV status. This is the Bella EBV negative. So it's really well proven that please avoid any transplant in EBV seronegative patients who are naive for EBV and doing a primary infection during the first 3 weeks when they are contaminated by the donor. So this is a safety. Principal conserved risk of highest in EBV negative patients. 1 PML reported in all MI treated. Tuberculosis is restricted to subjects. It's very keen because it's not done as BSET. We couldn't say it's BSET, this line. And belatacept regimen exhibit a favorable benefit and risk profile. So I just want to show you a very interesting data is in fact a switch. Can we switch a patient on CNI with a CAN under belatacept? This is a very small study with my friend from Barcelona and also from Toulouse. This is just recalling the problem we have with the CAN and decrease in renal function over the time under the CNI-based maintenance and try to shift them. Is it possible or not? Because people would say, as an immunologist who have a tolerance state under CNI, it is the same or not when doing a shift to a new drug acting on the T cell by the second signal blocking. It's renal function and safety. So this is the way they use. It's CNI, and then 2 arms. Patients were enrolled 170, 85 patients per arm, and you divide it in 2 arms. One arm continuous CNI-based regimen with a CNI with trough level between 100 and 250, and TAC, through serum concentration from 5 to 10, long-term extension, primary endpoint, and switch. And the switch was done 5 milligrams on day 1, 15, 29, 43, and 57, and then every 20 days, so once a month. And CNI was withdrawn during 4 weeks, not a brutal stop, 4 weeks of decrease. Because I guess this is very smart to do that and not to stop very abruptly. So this is the inclusion criteria. I mean, from 6 to 3 years post-transplant, CNA-based regimen, plus or minus MMF, ASA stable dose, and 18 years old, and GFR superior to 35 and less than 75, because this is the way that we have a lot of patients, between 35 ml and 75 ml of clearance. So exclusion was, in fact, a good thing. It's avoid higher immunological risk. Prior graft loss due to acute rejection, recent acute rejection, BAMF grade, higher acute rejection, and steroid-resistant acute rejection. Underlying renal disease that could affect GFR, like a recurring disease. As you may know, in nephrology, we have a lot of recurring disease on the graft, and infection, known hepatitis B and C, and known HIV and abnormal chest X-ray. So this is the status, switch to Bela, 84, 89, completed 1 year, it's pretty good, 81, and at the term, 81. So it's the same, it's easy, I mean, to compare those two populations. So this is a characteristic, I will go very quickly through that. It's easy to understand, so it's not a problem there. And this is the result, the change. Look, you start from 2.8, this is the major changes between cyclosporine and belatacept. The same at 2 years. Look, very strong differences between cyclosporine and belatacept. So it's very clear that you are gaining a lot when you are changing from a CNI to Bela as a shift. The problem is it not to see a sustain? It's true again. This is the cyclosporine, this is the belatacept. Here again, very close, strong differences between the two lines, and sustain over the time. This is the main change through year 2, switch to now also in continue versus stack. Here again, and you have a kind of increase of the clearance of the time because you have stopped the vascular toxicity of cyclosporine and also the tubular toxicity and stopped the fibrosis. You can maybe have gaining some ml of clearance of the time. This is at 2 years. I don't know exactly now it would be at 3 years, but this at 2 years is very, very clear that it was in this way. So this is the baseline GFR, this is the baseline CNI, and again was a lot of percentage, and the pre-randomizing diabetics. So the acute rejection, they have some acute rejection. So it's meaning that is not safe. It's not safe, but you can encounter some acute rejection when you are doing that. The number is very low, 7%, so it's not a lot, but you have to take care that the shift is sometimes associated with that. But you have also some acute rejection by just running the cyclosporine as usual after 2 years. So death and graft loss is comparable, 1 death in each arm, and the graft loss was 1 in belatacept, which occurred 18 months post-randomization. This is the safety, SAEs, serious adverse event, 40%, and 38% of serious infection was quite the same. So now this is the malignancies, no PTLD, tuberculosis 1, fungal infection 24%, 5%, so it's a little bit more. Viral infection 27, 24, CMV the same.
polyoma 3 on belatacept, 0 on cyclosporin A, herpes 10 and 10 and 7, and no autoimmune events. So this is, I want to stress, no PTLD in this setting because we are sure that those patients, French patients, are all ABV seropositive. This is the fungal, and I want just to go back. So the last one, before to speak a little bit about alefacep, is could we associate it with sirolimus? Here again, this is a very small trial of phase 2 done in Barcelona using Thymo plus Bela plus MMF. That is a change because it's not E2R. The second one was thymoglobulin plus Bela plus sirolimus, and the third one was thymoglobulin plus tacrolimus plus MMF. So it's a small study, 30 patients in each arm, and this is done at 1 month, and the checkpoint was 6 months and 12 months. So this is the rationale for that. Belatacept was given 10 milligrams per kilo over the time, 5 milligrams, so the same protocol that for Benefit and Benefit X. Tacrolimus 8 to 12 nanogram per ml, and then 5 to 10, and sirolimus, the usual dose you are using, 7 to 12, and at long term, 5 to 10. So this is the discontinuation. It's 5, and 1. Lack of efficacy is 3, 1, and 0. So really, it's not the fact that you have a lot of efficacy that the patient will drop out. And patient on study design, most of them, 85%, 81, and 97 were there. So it's easy, and you can use Bela plus MMF. You can use, because this is a basic ground, Bela plus sirolimus and tacrolimus plus MMF. So this is the patient survival, 97, 100, and 100. Graft survival, pretty good, 94, 96, 100. Steroid-free by 6 months, 82, 89, and 93, which is very interesting because in my unit it's very difficult to completely be patient steroid-free. DGF 18%, 15 and 7, acute rejection 4, 1, 1. So it's meaning that all those 3 arms have very low acute rejection episodes, and the mean GFR is 57, 57, and 47 because you are using tacrolimus and MMF. So really, here again, you are gaining something by using association of siro plus Bela or MMF plus Bela regarding to tacro plus MMF. And this is the protein creatinine ratio, 0.3, 0.5, and 0.3. So it's meaning not with sirolimus, you have not a heavy proteinuria that is sometimes usual to see under this drug. This is a serial infection, 18, 8, 13, so it's not a major one. Viral 6, 0, 10. The same, malignancy 4 in Bela plus sirolimus. It's surprisingly because sirolimus is supposed to be anti-cancer cancer events. Anemia was seen a little bit more on belatacept and MMF, and oral pathology stomatitis is as usual found in sirolimus harm, and proteinuria 12, 8, and 0. And this is for this reason. So the summary is belatacept, 1,000 patients, 2 years exposure, good efficacy, better renal function, safety and tolerability, combination of small molecule could be done, and for the next future would be new biologic, Bela and alefacep. I would show you some slide on alefacep, betacept and anti-CD40, and alefacep and anti-CD40. So this is just, I want to show you alefacep, and alefacep is also a bioreactant from Astellas, and is blocking the CD2 expression on memory and effector T cells. In fact, most of these effector T cells are CD2 positive, and long-life memory T cells, which are recognized in the graph, are always CD3 and CD2 positive. So alefacep is a LFS3 Ig fusion protein. We are mixing the exterior domain from LFS3 with an IgG, which in fact inhibits the second signal through the CD2 LFS3, and in fact induce T cell lysis in memory T cells. So this is the reason I was very interested by this molecule, because it's rich firstly memory T cell, which is a threat in transplantation or in immunology or in nephrology, because memory T cell is responsible for many autoimmune disease and for many nephrological disease. Alefacep is effective as monotherapy in non-human primate of transplantation, and also in psoriasis in man, and was commercialized in US for psoriasis, And alefacept is accepted as safe and effective monotherapy for psoriasis as a T-cell mediated disease. And also, you can treat some GVH after allogenic bone marrow transplant in human setting and in also in vivo setting. So it was also a very interesting molecules. So the endpoint was in fact here again to evaluate the efficacy of alefacept, and it was the incidence of biopsy-proven BPAR with T-cell mediated rejection. The secondary endpoint was incidence of BPAR, patient and graft survival 6 months, renal function assessed by MDRD 6 months, and the inclusion was patient and adult, and primary or retransplanted deceased donor kidney or non-HLA identical living donor kidney donation. And only the exclusion rate in these 3 continental studies, because it was in US, South America, and Europe, here again for alefacept, the exclusion were extrarenal organ and chronic ischemia time over 30 years old, and PRA superior to 20%. So it's low-risk patient in part. So this is the randomization for the day. Transplantation, alefacept from day 7, 50 milligrams sub-Q weekly, and then long-term evolution. The tacro-MMF steroid was a control group. At transplantation, 3 months is placebo from alefacept, and running state with MMF dose 750 milligrams BID, and the TAC level 0 to 28 and so on, and steroids. So it's typically the branch or the control group was tacro, MMF, and steroids. This is the disposition, quite the same. We have 110 patients in each arm. Adverse event, the number of completion was pretty good. The adverse event was 6% and 5%. Time to discontinue to rejection 2 and 1. Graft loss 3 and 4. And not filling exclusion criteria 2 and 4. And protocol violation was very low. Withdrawal consent very low. So completed at 6 months were 88% and 92%. So this is the donor demographics, practically the same in Richmond, no major differences. Chronic ischemia time, 14 hours, 13 hours, and DGF. The number of DGF was pretty low, 7% in alefacept arm, 12% for the placebo arm. The age was quite the same, and deceased donors was 83 and 80%. So this is, I'm sorry because it's appeared very bad because there's, for unknown reason, when I put that in my key, is dropping down. The tacrolimus mean trough level was the same, as you can see. So it was not violation of the protocol. And alefacept, the curve was alefacept and the curve was the control. The tacrolimus mean trough dose was remained the same for the two groups because there are no major differences during the time. This is now the mycophenol acid, the main daily dose. Here again, the quite same over the time. Here again, so no major differences in two groups for CellCept. And now this is the trough level from MPA again over the time. So the very same curves between alefacept and placebo. The alefacept is in red. And now this is the alefacept plasma concentration. So it's a pretty big variation over the time. So because as you may know, the problem with bioreactants, the metabolism of bioreactants is very dependent upon the genetic background of each of us, depending on the way that you are metabolizing amino acid and so on. So it's not astonishing to see that the mean curve is this one, but your standard deviation is very high. And as soon as you stop, you can see here again, you have remnant molecules inside the serum for a couple of time, 10 days afterwards. So it's meaning that as you have the chemical compounds, and the half-life of the chemical compounds is very well known because it's metabolized by the liver, it's metabolized by the kidney and so on. For the bioreactant, the metabolism is very quite different. It's metabolized by the immunological tissue, monocyte, macrophages and so on. So it's quite different from one to the other one. So this is the very important thing, the T lymphocyte subset. And the very strong point, if you see the non-memory T cells, CD4 and CD8, no major changes between alefacept and the control group. The same for the CD8 non-memory T cells. And if you see now the memory T cells, CD4, CD45 arrow positive, CD4 and CD8, look, a very good drop, very strong drop of the long-life memory T cell, seen either for CD4 and for CD8. And both are engaged against T-cell defense, against allografting, and also against viruses. So this is the biopsy-proven T-cell mediated rejection, and this is maybe one of the main causes that Astellas stopped the development on alifacept, because we saw a little bit more acute rejection until during the trial between the control group and the alifacept story. It's 6.6% and 11%, close to twofold more of acute rejection. So really, it's a prime of maybe program protocols, but also efficacy of alifacept. So the patient survival, it was easy to understand. It was not deleterious for the patient survival, they're quite same, and also for the different causes that we saw between alifacept and the control group. So it's meaning also that all the acute rejection were easily treated and cured by increased steroids and using also bioreactant like ATG. The graft survival and intent to treat, here again it was quite the same from alifacept and the placebo group. So the renal function remained very good over the time. Here again quite same until 6 months post-transplantation, and this is the MDRD formula, quite the same over the time with alifacept. So this is the incidence of selected events. This is infection-related, 23%, 26%. Renal-related, 16 and 13. Cancer-related, a little bit more. And one explanation is because we are reaching long-life memory T-cell. Maybe it's a little bit increase of cancer in these settings, 0.9% in the placebo. Cardiac-related 1 and 2.1. So any infection, 61, 57. UTI, the same. CMV, twice more in alifacept, because you are reaching, here again, long-life memory T-cell, which are in fact controlling the CMV replication and ABV replication. But surprisingly enough, BK viruses is less in alifacept than in placebo. So no explanation for that. EBV infection only 1 in alifacept, and septic shock was 1 in alifacept and 1.9 in placebo. So this is the malignancies for alifacept: basal cell carcinoma, cervix carcinoma, lung malignancies, pheochromocytoma, post-transplant lymphocyte disorder, and renal neoplasia. It's very surprising because most of this cancer, in fact, must pre-exist prior to transplantation. And unfortunately enough, they fall down in this is clinical investigation. I mean, this is because it's science. You cannot predict what's going on, because cervix carcinoma and basal cell or lung malignancy is really pre-existing to the graft. And we have on the placebo only 1 colon cancer. Here again, it's maybe pre-existing to the transplantation, but it's appear like that. And this is research. So summary and conclusion is alifacept was not statistically or numerically superior to placebo. Alifacept was not statistically different than placebo in the rate of patient survival. Alifacept was similar to placebo with regard to the mean serum creatinine and GFR by MDRD. Infection-related assays were similar in both treatment groups. Alifacept had numerically more CMV but less BK viruses. Malignancies occur more frequently in the alifacept group. That's true. Alifacept was associated with a significant reduction of memory T-cell return. That's true. And finally, taking this slide in consideration, it took 6 months for Astellas US, not Astellas Europe, Astellas US to say what's going on with alifacept. It was only marketed for psoriasis, very severe psoriasis. One of the main problems for psoriasis in US now, they have monoclonal antibodies against CD23, and it's giving 100% of healing. So the market is very competitive between alifacept and this new setting. So the decision after 6 months, because I was proposing a lot of things, associating alifacept and belatacept, one is acting on memory T cell, the other is active on T cells. And in fact, they took the decision last August, and they came in Paris. We have a long advisory board for 1 day, and after 1 day, the decision dropped down from US, saying they would stop definitively the alifacept trial in a large phase 2, associating or not with other bioreactants, but the decision from Astellas US was to stop that. So it's maybe another problem that I'm sometimes not very lucky, because I was a leader from FTY. You remember FTY? 70220, and was stopped by Novartis after the phase 3 because they have a Fondi problem. You remember also FK778, an antipyramidal drug. Here again, I was involved in a phase 3, they stopped. So I'm not so very frequently a lucky guy. Sometimes it's winning, sometimes it's losing. So I want just to finish my time because it's only 33 seconds. I'm just right in time and saying thanks so much for attention. I'm very happy to be there among my colleagues for the North region in Israel and to be with you and to exchange with you some experience I have in clinical investigation with these two drugs. Thank you so much for your attention.